Hello, everybody. This is my name is Nagla Ilarian. I'm with the Texas Collaborative for Healthy Mothers and Babies, and I'm very, very happy to announce today's webinar on contraception discussion with patients. We have our speaker today is from Power to Decide. Her name is Robin Watkins. Robin is the Director of Healthcare at Power to Decide. She is the campaign to prevent unplanned pregnancy. Ms. Watkins works with healthcare systems, payers, and health social service providers across the country so that all young people, no matter who they are, where they live, or what their economic status might be, have the power to decide if, when, and under what circumstances to get pregnant and have a child. Ms. Watkins comes to Power to Decide with a wealth of knowledge and experience in family planning, most recently working at the Unity Health Care, the District of Columbia's Title X grantee, and the largest federally qualified health center, delivering direct patient care as well as spearheading sexual and reproductive health quality improvement projects. Ms. Watkins earned her Master of Science, Midwifery and Women's Health Nurse Practitioner degree from Georgetown University School of Nursing and has a BS in both nursing and public health from Johns Hopkins University. Please help me welcome Robin Watkins.
Thank you so much for having me here. I'm going to go ahead and share my screen so that we can get started with the webinar. But I am so excited to be here and talking with you all today about contraception. All right, so I believe I'm now sharing my screen. And that's as you have questions or if things come up during the time that we're talking today, if you can go ahead and enter those in the Q&A box that should be down at the bottom of the controls for the meeting. There'll be some natural breaks in our discussion where I'll be able to answer some questions. And then again, if you have ongoing questions or you think of something tomorrow or as you're headed home this evening, I'll provide you all with my contact information so that you can go ahead and reach out. If you are having technical difficulties, we would ask that you use the chat box that is down also on that bottom panel. So the Q&A for questions during the presentation, and then if you're having technical difficulties, you can just write into the chat box. Again, my name is Robin Watkins. I'm a certified nurse midwife and a women's health nurse practitioner. And then for our webinar today, we're going to be talking about the basics of contraception. And so by the end of this training, as I go through all of the material, we'll be focusing on increasing knowledge around the full range of FDA-approved contraceptive methods and how to improve your confidence and comfort. This is specifically for healthcare providers who are counseling and offering contraceptive services, such as medicine physicians and other primary care providers, including nurse practitioners. There may be others on this call who do not directly offer those services. However, knowledge about specific methods of birth control and contraceptive counseling that we'll talk about today can help you to better prepare clients for the services that they'll receive. So for example, knowing that a method of birth control requires, or a specific method of birth control requires a visit to a healthcare provider to start using, like an IUD or an implant, versus methods that can be used without a visit to a provider, like condoms or the withdrawal method, can help clients most efficiently access the birth control method of their choice. So as we go through the discussion today, by the end, I anticipate that you will all be able to name 2 features of each of the methods, and then at least be aware of the CDC's medical eligibility criteria, and for providers be able to use the medical eligibility criteria. And then just for everyone to commit to providing all counseling and services in a way that support clients in a non-judgmental and unbiased way. So Before we dive into talking specifically about the methods, we'll talk briefly on an overview about providing contraceptive counseling. So one of the best ways to meet your client's needs and to connect is by providing client-centered contraceptive care, sometimes called shared decision-making. It's really just a fancy way of describing a respectful conversation where one side has more technical knowledge and expertise, in this case on birth control methods, and on the other side, in this case of the client, they are the expert in their own life. So both sides of the conversation have expertise to bring and share. I really like this definition here of patient-centered contraceptive counseling. Involves treating each person as a unique individual with respect, empathy, and understanding, providing accurate, easy to understand information about contraceptive methods based on the patient's needs and goals, and assisting patients in selecting a contraceptive method that's the best fit for their individual situation and a manner that respects the patient's preferences for decision making. So there's a lot packed into that, but I think this definition really brings a lot of those pieces together. So here you can see on this next slide the elements of high quality counseling. So these elements of providing quality counseling from the CDC go beyond contraceptive counseling, but they are incredibly important when people are making decisions about contraception and birth control. So these are things that you're likely already doing in your practice, things like establishing and maintaining rapport with clients by making small talk, pointing out health supporting behaviors, and positive feedback. This sort of maintaining and establishing rapport really starts before patients even see a provider. So a patient who has a negative interaction with the front desk staff or has trouble making an appointment or waits for a long time before seeing a provider may not be ready to have the kinds of conversations about contraception or anything else related to their health. So really things to think about as you embark on this counseling process. The second principle is to assess the client's needs and personalize discussions accordingly. So in this, here one key question can open the door to conversations, but it's really important to continue the conversations with the clients to explore and talk about their own personal needs. The third principle to work with the client interactively to establish a plan should include setting goals, discussing possible difficulties with achieving those goals, like sticking with birth control pills, or developing action plans to deal with potential difficulties. The fourth principle is to provide information that can be understood and retained by the client. And providers should really think about offering information that is both affirming and useful. For example, using evidence-based bedside materials, which we'll talk about a little bit later, can help ensure that clients get the information that they need in a way that speaks to them. And the fifth principle of quality counseling is to confirm client understanding. It's important to ensure that clients have processed the information provided and discussed. One technique that is commonly used is a teach-back method, although there are many others to ensure that clients have the information that they need, not only to make decisions about their contraceptive methods, but to use them consistently and correctly. So this next slide, when clients are making decisions about their contraceptive or birth control methods, they consider a variety of factors. Some factors are more and less important to individual clients. While some clients may feel that effectiveness or how well a method prevents pregnancy is most important, that may be less important to others. This list of common factors is not all of the factors that someone might consider or prioritize, and what is most important to an individual may change over time based on relationships, pregnancies, births, and other major events, including how much a particular method may change their bleeding frequency or predictability or amount, how much control they have over starting and stopping a method, and how quickly they may return to fertility after discontinuing or stopping a method. The overall cost to obtain and maintain a method, again, how well or how effective a method is at preventing pregnancy, how much effort is or how challenging it is to get and use a method consistently, whether the method has other non-contraceptive benefits from using it, like decreasing PMS symptoms, preventing certain types of cancer, or lessening bleeding with your periods. So privacy or whether anyone knows that they're using a method, and who they want to keep their method private from can be a determining factor for some, and whether the method protects against sexually transmitted infections. So as you determine with your clients which factors are most important to them, you can use client-centered counseling. For example, if it's very important to a client to use a method that is most effective at preventing pregnancy, you would start by talking about methods that are most effective, things like IUDs and implants. If your client is not sure or thinks that everything is most important, it can be helpful to use a 1 to 10 scale to gauge ambivalence and determine which of the factors is actually most important. And here you can see that while clients are considering all the factors from the last slide, they do so in a complicated world. For better or worse, partners, providers, families, and friends all directly influence contraceptive decision-making. And then all of us live in a world that's influenced by our culture, societal norms, media, and the ability to make decisions about our health is ultimately impacted by the healthcare system and our political climate. So just taking that into account, that the provider and the client interaction is one small piece of this overall complicated system in which people are making decisions about their birth control and pregnancy desires overall. So some of you who are on this call today have been trained to use one key question as a way to start a conversation about reproductive health by asking, would you like to become pregnant in the next year? And giving 4 response categories: yes, no, unsure, and okay either way. Others of you may use other tools to start these conversations, but for the purposes of this webinar, we'll use one key question to frame the conversation. If you need more information about one key question and training, please leave a note in the chat box, or you can reach out after this presentation. So I'll take a moment here before we start talking about the methods of birth control to see if anybody has questions or about the contraceptive counseling piece that we just discussed. And I'll just, all right, so I don't see any questions, so we're going to go ahead and start talking about the different methods. So as we go through, there we go. So here's an example of how we'll go through the different information about the methods of birth control. So we'll consider the methods based on some of the factors that we just talked about in the previous slides. So again, bleeding changes, control, effectiveness, effort, privacy, other benefits, STI prevention, and cost. So the first method that we're going to talk about, for the purposes of this presentation, we're going to start talking about some of the most effective methods and then go through all of the methods, but we'll start with the ones that are most effective. So the IUD is a small T-shaped piece of plastic that's placed into the uterus that changes the way that sperm can move and prevent them from fertilizing an egg. So IUDs are highly effective methods of birth control placed in the uterus by a provider, making them super easy, set it and forget it birth control. There are currently 5 brands of IUDs on the market: Paragard, Liletta, Mirena, Skyla, and Kylena. The no hormone option, the Paragard, the copper IUD, does not affect the timing of menstrual cycles, but could increase the flow or increase the amount of cramping for some. The progestin or the levonorgestrel IUDs tend to reduce cramping and make periods lighter or go away altogether, which is safe when using these methods. And some women even use these IUDs just for that benefit. While IUDs are very cost effective over the long term, there may be upfront costs depending on insurance. It's also important to note that IUDs are safe for almost everyone with a uterus, including those who have never been pregnant, those who smoke or have high blood pressure or diabetes, and are safe to use while breastfeeding. The next method that we'll talk about is the implant. a small rod inserted under the skin of the upper arm that slowly releases progestin, a hormone to keep the ovaries from releasing an egg, and thicken cervical mucus, which can additionally help block sperm from getting to the egg in the first place. So implants, just like the IUD, are highly effective, super easy, set it and forget it birth control, placed by a provider with a quick procedure. Just like the IUD, implants are very cost effective over the long term. However, there may be upfront costs depending on insurance. Implants are also safe to use for almost everyone who's trying to prevent pregnancy, including those who smoke, have high blood pressure, diabetes, and are safe to use while breastfeeding. There is currently one implant on the market. The name brand is Nexplanon. Previous name brand of a similar product was Implanon. The Nexplanon is FDA approved for 3 years, and evidence shows that it is actually effective for up to 5 years. The most common side effect with the implant is irregular bleeding. Overall, those who use the implant have less bleeding than people who are cycling naturally. However, the bleeding can be unpredictable, with some having bleeding every day. For those who use the implant, it's important to counsel them up front that this bleeding, this can be unpredictable and is something to be prepared for when you are using the implant. So it's something to have conversations about before someone starts using an implant. So bottom line, if you're using an implant, you need to be okay with irregular bleeding. The implant is also an incredibly private method. It's not something that unless you show it to someone, they know that you are using it. All right, so we're gonna take a break here for a quick quiz question. So the IUD is an appropriate choice for A, adolescents, B, people who have had children, C, people who have not had children, or D, all of the above. Oh. We'll give everyone just a moment here to vote. Maybe another 10 seconds or so. And we can go ahead and close the voting. Great. So this is a pretty straightforward one. The answer, pardon my slides, there you go. All of the above. So the data are really conclusive. Overall, women using an IUD have no increased risk of pelvic infection or infertility compared with women who use other types of birth control, except for condoms, which do help to prevent sexually transmitted infections. But IUDs are safe, low maintenance, super effective, and can be used by most people with a uterus. The next method that we'll talk about is sterilization. So sterilization is a procedure that closes or blocks the fallopian tubes where the eggs and sperm meet, or the vas deferens, the tubes that carry sperm, to keep the eggs and sperm apart and prevent pregnancy. So if they can't meet, they can't hook up, and you won't get pregnant. So sterilization is a highly effective method of contraception. And while there are several different methods of sterilization, they all require a procedure by a provider, and all methods of sterilization are permanent. Some methods, like vasectomies, can be done in the office, but for many of the others methods of sterilization, they may include an overnight hospital stay. So just like the IUDs and implants, sterilization would be cost effective over the long term, since once someone has a sterilization procedure, they're using it for the rest of their life. There may be incredibly large upfront costs depending on insurance, and especially if a hospital stay is required. Sterilization is another method that is incredibly private, and that once the procedure is done, but if someone requires an overnight stay in a hospital or getting the procedure done is not necessarily the most private occurrence. The number one most private method is the shot. So the shot is an injection given once every 3 months, contains progestin. Again, that works by preventing the ovaries from releasing an egg, and also thickens cervical mucus to help block sperm. Given every 3 months, and it is effective for preventing pregnancy for those 3 months. However, the hormone that is in the shot may stay in your body and decrease the chances of getting pregnant for some up to a year. That does not mean that it continues to be an effective method of birth control during that time. It is that it may linger for some, and it's hard to know or predict who will be affected by that. So if your client feels it's very important for them to be pregnant within the next year or in a certain amount of time, this may not be the best method for them to consider. And just like the implant, the most common complaint with the shot is irregular bleeding. This could mean spotting in between periods or having longer, heavier periods. And on the other hand, many women have no periods at all. Again, bottom line, you need to be okay with irregular periods when thinking about using the shot. It's also good to know upfront that the shot may cause changes in appetite, potentially leading to weight gain. It's common for some women to gain around 5 pounds in the first year of using the shot, while other women report gaining nothing. This method is it does not prevent you from getting any sexually transmitted infections and has slightly more effort involved than something like the implant or the IUD, since you do need to see a provider every 3 months to get another shot. The next method we'll talk about is the pill. Also called oral contraception, is the most commonly used method of birth control in the United States. Taken once a day at the same time every day. There are lots of different pills or different brands of pills on the market, and new ones coming out all the time, including a new progesterone-only birth control pill that was approved by the FDA last week. Most of these pills work by releasing hormones that keep the ovaries from releasing an egg. They contain both estrogen and progestin. And the hormones, or some are just progestin-only birth control pills. The hormones also thicken cervical mucus, helping to block sperm from getting into the uterus in the first place. So pills also offer protection from some issues like endometrial and ovarian cancer. Because they reduce the amount of bleeding that people have with their periods, they also are preventative for iron deficient anemia, or can help manage anemia. Because your ovaries are not cycling, they can also help prevent some ovarian cysts. And because of the thickened cervical mucus, there is some decreased incidence of pelvic inflammatory disease. Pills, on the other hand, require more effort, since you do need to take them at the same time every day. There are, as I said, lots of different brands of pills. Some come in 21-day packs, others come in 28-day packs. Some are rectangles, some are circles. Some will help you have a regular period every month. Others let you have a period every 3 months. And some even let you skip your period for an entire year. The most important to remember is that they generally all work in the same way and have to be taken at the same time every day. The patch is a thin beige piece of plastic that looks like a square Band-Aid. It's a little less than 2 inches across. There is currently one brand of patch on the market, Xulane, spelled with an X. Previously, Ortho Evra was a brand that was on the market that is no longer on the market. The patch is stuck on your skin like a sticker and gives off the hormones estrogen and progestin that prevent the ovaries from releasing an egg. The patch is changed once a week, and people will need to pick up a new prescription for the patch at their pharmacy. So the pill, the patch, and the ring all work in similar ways and have similar benefits beyond just preventing pregnancy. The biggest difference between the pill, the patch, and the ring, which we'll talk about next, is how you take the hormones. So the pill, by taking a tablet, the patch on your skin, or a vaginally inserted ring. So the ring is a small bendable ring inserted into the vagina, left in place for 3 weeks at a time, and then taken out for a 4th week. That is during the time that the ring is out. Most people would have a period. If people want to skip their period, they can continue using the ring for 4 weeks, removing it and replacing it with a new Nuva ring at that time. The ring, just like the pill and the patch, the combined hormonal pill and patch, work by preventing the ovaries from releasing an egg and thickening cervical mucus. So neither the pill, the patch, nor the ring prevent sexually transmitted infections, but they can all be doubled up with or used with condoms to prevent infection. The ring is slightly easier to use than the pill or the patch because there is less to remember. Although it is tricky to remember to use them correctly, or it can be tricky to use them correctly, Bedsider does have some resources which you can recommend to clients to help them remember to take the pill every day at roughly the same time, change their patch on the same day every week, or switch out the ring every month no matter what. Your clients can download the app from the Apple Store or on Google Play and sign up for reminders for their pill, patch, ring, and the shot as well. All right, so we have another quiz question. So what is the most commonly used form of birth control in the United States? Give everybody about 30 seconds to fill in their answer. Got another 10 seconds. And we'll go ahead and close the poll. Great. So you are all correct. The most commonly used method of birth control in the United States is the pill, followed closely by condoms. So on that note, we'll talk about condoms. So condoms are one of the most popular forms of birth control out there. And both condoms and internal condoms prevent pregnancy and lower the risk of sexually transmitted infections by keeping sperm inside of the condom and out of the vagina. So condoms, sometimes called male condoms, are placed over the penis, and internal condoms, sometimes called female condoms, are a pouch inserted into the vagina. Condoms come in hundreds of shapes and sizes, with lube and without. And there's currently only one brand of internal condoms, the FC2, on the market. The best thing about most types of condoms is they help protect against sexually transmitted infections, including HIV, while also decreasing and preventing the chances of pregnancy. Condoms do not require a provider visit and are relatively cheap and easy to find from pharmacies, health centers, to supermarkets, and even online. But you do need to use them every time you have sex, so partners have to be in agreement about using them. We mentioned this before, but using a barrier method like condoms, internal condoms, or dental dams may be another method of used with another method of birth control to prevent sexually transmitted infections. So just because someone is meeting their needs for contraception and preventing pregnancy, they may also have a risk for a sexually transmitted infection. So using both a dual protection, so protection from sexually transmitted infections at the same time as using a method of birth control can be key for some clients. The next method that we'll talk about is spermicide. So this describes a bunch of different creams, films, foams, gels, and suppositories that contain chemicals that stop sperm from moving. While spermicide can be used alone, it can also be paired with other methods like the diaphragm. The diaphragm or the cervical cap. These are slightly differently shaped domed cups made of silicone that are filled with spermicide and inserted through the vagina to cover the cervix and keep sperm out of the uterus. It's important to remember that for these methods, the diaphragm and the cervical cap, to work effectively, they need to be used with spermicide. These methods are less effective than hormonal methods that prevent ovulation. So if it's very important to a client to prevent pregnancy, this may not be the best method for them. Users will also need to feel comfortable placing these methods inside of the vagina. However, they can be placed hours before sex, so they don't have to interrupt the heat of the moment like condoms do. And they can be completely private. You just have to be able to predict when you're going to have sex. So these methods, along with condoms, have high levels of control since clients can start and stop using these methods without seeing a provider. So for some, that may be an incredibly important factor to consider. The next group of methods that we'll talk about are behavioral methods like fertility awareness methods or natural family planning. These are all about tracking the menstrual cycle to determine the days when you can get pregnant. The tricky part is actually knowing when those days are. To do that, you'll need to pay close attention to your body and its patterns. And some of the different ways that people monitor their day-to-day fertility include using a standard days method, which can be done using cycle feeds or a new FDA-approved app to track their fertile window, which involves a combination of thermometer and app. There's also cervical mucus monitoring, where people check their cervical mucus to indicate when their fertile window is. Those changes in cervical mucus that indicate a fertile window. Temperature monitoring methods, like checking basal body temperature or combined with cervical mucus checking, can help determine whether ovulation has already happened. So these methods can be good if you have a regular cycle and for those who are very committed to using them. The other behavioral method that we'll talk about is the lactational amenorrhea method, which can be used by women who are breastfeeding their infants exclusively, so giving nothing but breast milk, and in the first 6 months of the baby's life and have not had their period. There are several criteria that need to be met for lactational amenorrhea to be used as a method of contraception. And you can go online to Bedsider or to the Fertility Awareness Center to find out more information about how to specifically use these methods or to counsel your patient. So they can be really good and really committed users can be really successful using them, especially those, as I said, with regular cycles and those who cannot use other methods due to religious reasons, but they do require both partners to be on board with using them and to abstain from sex when you are during a fertile period. And so they take discipline and practice, which means they're not highly effective methods overall. The next method that we'll talk about is the pull-out method. It's the oldest form of birth control on the planet. There's not really much to explain. You don't ejaculate in the vagina, and therefore sperm stay away from an egg. The pull-out method can be used with other methods like behavioral methods or with an IUD to increase effectiveness. But it is another method that requires both partners to be on board and requires users to have extreme body awareness to make it effective. On the plus side, it's free, does not require a visit to a healthcare provider or a clinic, and while it's not a highly effective method, it's definitely more effective than no method at all. It's a method that is incredibly private from, it's not private from your partner, but it is private from family members or roommates. So no one other than you and your partner needs to know that you're using this method. All right, so back to quiz time. So which of the following statements are true? A, condoms are your best protection from STIs. Diaphragms are just as effective without spermicide. The pull-out method never works. Behavioral methods like fertility awareness only work while you're breastfeeding. E, none of the above, or F, all of the above. All right, so I'll go ahead and give you all another 15 seconds or so to complete the poll. I think we can go ahead and close it. So the answer is A only, and it looks like the majority of people did respond. So condoms are your best protection from STIs. So the only other method that we'll talk about today that is effective at preventing sexually transmitted infections is abstinence. So not right now is our way of saying no vaginal sex. So it's a great method as far as effectiveness is concerned if you use it 100% of the time. You're guaranteed not to get pregnant. And if you're avoiding sexual activity altogether, you'll be safe from sexually transmitted infections. However, if you are having non-vaginal intercourse, you can still be at risk for sexually transmitted infections. So having anal or oral sex still increases your chances of having a sexually transmitted infection, even though you're preventing pregnancy. So abstinence, just like withdrawal, is free and can be used by anyone at any time. It does, however, involve a whole lot of self-control, discipline, and commitment from both partners. And that can be hard to stick to and maintain over the long term. The next method of birth control, the last one that we're going to talk about, is emergency contraception, which can stop a pregnancy before it starts. That means that emergency contraceptive pills are not the same as an abortion pill. There are different types of emergency contraception to choose from, and they all work up to 5 days or 120 hours after unprotected sex. But using emergency contraception sooner rather than later reduces the possibility of getting pregnant, especially when using the levonorgestrel emergency contraception. So it doesn't matter whether you've had a whoops moment, taking pills, didn't pull out in time, or got swept up in the moment. EC can lower the chances of getting pregnant after sex has happened. And EC only prevents a pregnancy. It wouldn't interfere with an established pregnancy. The most effective method of emergency contraception is a copper IUD. The copper IUD is just as effective on day 5 as it is on day 1 and is not affected by your client's body weight or BMI. Other methods of emergency contraception, like over-the-counter Plan B one-step and prescription Ella, use hormones to prevent ovulation. Ella and the copper IUD, just like the copper IUD, is just as effective on day 5 as day 1. However, ulipristal acetate is less effective in those with a BMI of 30 or greater. That doesn't mean that it's not effective. It just means that it may be less effective. And levonorgestrel emergency contraception is less effective in those with a body mass index over 25. So for anyone who is overweight, and they are not interested in a copper IUD, you would recommend the ulipristal acetate, Ella, but that does require a prescription. So helping your clients think about whether they need access to either prescription or provider-controlled methods for emergency contraception ahead of time can be incredibly helpful. Also important to note that the levonorgestrel emergency contraception is also more effective the sooner you take it. The effectiveness does decrease over time for the levonorgestrel emergency contraception, unlike the other two. All right, so we've got a quick question here about emergency contraception. So which of the following statements are true? A, you need a prescription to get all methods of emergency contraception. B, the copper IUD can be used as emergency contraception. And C, you can get emergency contraception over the counter at most drugstores. Or D, B, and C. Oh, I don't see the poll. Oh, there it is. Great. All right, we'll get another 10 seconds here. Oh, it looks like these quiz questions are for our next quiz. So the correct answer here is B and C. So hopefully all of you, as you're reading through these, thinking about them, that is correct. So you do not need a prescription to get all the methods of emergency contraception, but there are methods of emergency contraception that do require a prescription. Again, they all work by, the hormonal methods of emergency contraception work by preventing ovulation. So they are less effective if ovulation has already occurred. So I'm going to take a moment here before we talk about putting it all together and choosing a method to see if there are any questions. I am not seeing any questions right now. So if you do have something, oh, I did get one, right? Okay, no questions right now. Great. All right, so let's go ahead and we're going to talk about method selection. So through research we've done here at Power to Decide, we know that many women use short-term or less reliable contraception because it's what they could afford, what they've always used, or what they're familiar with. Specifically, the ones we talked about, the most commonly used methods, pills and condoms. Many women are not aware of the current options of contraceptive methods available and how they work. But it's also important to remember that what we think might be most important to our methods, to our patients about a method, may not be what they think is most important. So during the research, some of the research that we've done, we found that that providers prioritize effectiveness and the duration of action for a method. So thinking about a long-acting method that's highly effective is something that providers prioritize, whereas users did not tend to prioritize those above things like side effects and what the experience of using and obtaining a method was. So as you're going through and providing contraceptive counseling to your clients, some sample clarifying questions are here on the screen. So these are questions to get the conversation started and to continue the conversation. So are you currently using birth control or doing anything to prevent pregnancy? So some people might not think about things like the withdrawal method or using fertility awareness as birth control. Rather, so asking, are you doing anything to prevent a pregnancy, can make sure that you get a complete answer from a client. Asking clients about their satisfaction with their current method, and if they're not satisfied with their current method, asking them why not. So what is it that's keeping them from being satisfied with their method? If they are satisfied with their method, particularly if they're using pill, patch, ring, or depot, thinking about when the next time they need a refill or a new shot is, or with an implant or an IUD, confirming with the patient that they know the date that their IUD or implant was placed and how long it's effective for, and that they can have it removed at any time. Also asking clients, how important is it to you to prevent a pregnancy right now? Or asking, what's most important to you about your birth control method, looping back to some of those factors that we talked about in the beginning that people would consider as they're deciding and choosing on a birth control method. It is bound to happen as you go through and provide contraceptive counseling that people will ask you challenging questions. Clients will ask you tough questions and ones that you also might not have the answers to. So when responding to challenging questions and statements, it can help you to maintain rapport, to first validate their question or concern before segueing to correcting misinformation. So again, start by saying, that's a great question, or I hear a lot of people asking about that. And then segueing to correcting the misinformation in a supportive way. I'm glad I have the chance to clear this up for you. The fact is, and also remember, if you don't know the answer, it's okay to say so. So people can tell when you're faking. And if you don't know the answer, it's best not to make something up or to guess. It's also, if you're not a clinical provider, it's always okay to refer to a clinical provider. And if you are a clinical provider, it's always okay to refer to another clinical provider. We don't all have to be experts in everything all the time. We've mentioned Bedsider a couple times here, and for those of you who are not familiar with Bedsider, it's an online birth control support network created by Powered to Decide and vetted by medical professionals that delivers information about the full range of birth control in a voice that resonates with young people. Bedsider is independent, honest, unbiased, and accurate. And some of the tools that are available to users, you can see screenshots of here. Our Where to Get It tool, with the most comprehensive database of health center locations in the US, helps users find health centers, birth control delivery, and emergency contraception when they need it. There's also a Build Your Own Method comparison tool, which allows users to compare methods, and there's also Bedsider content with over 1,000 original articles, 250 videos, photos, frequently asked questions about birth control, side effects, and more. So if you're not able to offer the counseling, or you're not able to provide as much counseling as you'd like to during your visit, you can always refer patients to Bedsider after a visit and for follow-up. Some other resources that are available for clients when choosing a method of birth control are wall posters, these small postcards that have just enough information about key features of methods, and these decision support tools like the tiered effectiveness and emergency contraceptive charts that you see here. These can be given to clients to help them visualize their contraceptive options. And as we've discussed, helping clients choose a birth control method that is, quote, best for them is really about finding a method that's the best fit for their individual situation, needs, and goals, even if that is no method at all. And I see a question has come through, and I'm actually not able to get back to that right this moment. So hopefully I'll be able to get to that in a moment.
Would you like me to read the question for you?
I can see it now.
Okay.
So the question is, before we start talking about the medical eligibility criteria, which I think might answer this question a little bit, the question is, how do you determine what pill to prescribe a patient? So we'll talk a little bit here about the medical eligibility criteria for contraceptive use from the Centers for Disease Control. Let me go to that slide just so you can see it here. But the thing to remember is that most pills are well tolerated by most people. So there really isn't a wrong answer about what pill to prescribe. I personally start patients generally with a monophasic pill that has 30 milligrams of estrogen in it. So that is sort of in the middle and gives us room that if they are having breakthrough bleeding, that we could increase the amount of estrogen, but also if they're having other side effects, that we could decrease the amount of estrogen. So it gives us room to play around with that. And then you can always change the progestin. So most combined hormonal contraceptive pills, they have the same estrogen in differing doses, and they are different progestins. So really thinking about individualizing that for a client. There are some pills or some progestins that are better if people are having symptoms like body hair or acne. And so really thinking about that individual client. And the answer ultimately is that most pills are well tolerated by most people, so there really isn't a wrong answer. So hopefully that answers your question. As I talked about, most birth control is safe for most people. However, not all methods are a good fit for everyone. So thinking about birth control pills that have estrogen in them, there are some clients that are not a good candidate for estrogen because of the increased risk of blood clots and stroke. So it is important also to remember that pregnancy increases the levels of estrogen and is a health risk in terms of increasing risks of heart attack and stroke, the same way that birth control estrogen-containing birth control does. So thinking about whether the method of birth control or whether pregnancy, and really thinking through those decisions can be helpful. So this summary chart here of the U.S. medical eligibility criteria for contraceptive use is the best resource available for providers on this topic. So they have done all of the research and put it all together in one place so that you can use this chart to help determine for an individual client which methods will be a good fit for them in terms of safety. So putting that into action. Okay, so when you're looking at this chart, the way that I think about this is green means go, the dark red or the 4s means stop, and light red means caution. So 3 means caution. So overall on that chart from the last slide, you can see, or even here for those who are postpartum and breastfeeding, you can see that it's overwhelmingly green. That means that patients can use those methods without restriction. Inserting an IUD less than 4 weeks after delivery, which you can see there under so less than 4 weeks after delivery for a woman who has had a serious infection related to giving birth or postpartum sepsis is a category 4. Estrogen-containing methods like birth control pills in the first 3 weeks are also a category 4, but then used with caution, so a category 3 in the postpartum period without an additional risk of having a blood clot or a stroke. For those who want to start pills to prevent pregnancy in the first 6 weeks after delivery, they can be started with a progestin-only pill and switch after 6 weeks or at a time after those 6 weeks have passed. The other thing to consider when starting a method of birth control is that most methods can be started the same day that the patient is seen. You may already be counseling patients that there is no reason to wait until their next period or wait for a Sunday to start their pills when you can be reasonably certain today that they're not pregnant. And many of us do this already on a routine basis. So you can be reasonably certain that someone is not pregnant when it is less than 7 days from the first day of their last normal period, when someone has not had sex since their last normal period, when someone is less than 7 days after a spontaneous or an induced abortion, is within 4 weeks of delivering a baby, or is exclusively breastfeeding their baby less than 6 months and does not have a period. So this is from the U.S. Select Practice Recommendations from Contraceptive Use, which is another CDC document that helps guide when to start using contraceptive methods and ongoing use of those methods. So as you can see, any of the methods can be started at any time that the provider is reasonably certain that someone is not pregnant. For more detailed look at how to determine whether someone is not, or to be reasonably certain someone is not pregnant, whether they need emergency contraception, and whether you can start a method today, the Reproductive Health Access Project has the Quick Start algorithm, which is incredibly helpful to those who are offering same-day access to contraception. As I said, when a client does not want to be pregnant, another factor to consider when you're quick starting them is their need for emergency contraception. So anyone who has had unprotected sex in the last 5 days and does not want to be pregnant should be offered emergency contraception. For clients who are inconsistently using other methods like pills or condoms, you can consider preemptively offering emergency contraception referrals or having them go ahead and buy over-the-counter methods of emergency contraception, since using them sooner makes them more effective. In cases where you cannot be reasonably certain that a client is not pregnant, it's okay to consider and offer EC before bringing them back for another method. So that would be using it as a bridge. So we'll talk about this here in this next slide. So if on the day of your visit, a patient is either not ready to start a method, you're not able to offer the method, or you cannot be reasonably certain that someone is not pregnant, you can bridge them or help them get to an appointment with a healthcare provider, or help them get to a point where they can start another method of contraception by using other methods, including condoms, pills, and emergency contraception. So just thinking about what services you are able to offer at your site, and that's different for providers and varies among providers and sites. So if you're not able to offer a patient's desired method on site or that day, thinking about who and where you would refer them to and what the process for getting that method would be is helpful as you're counseling patients about contraceptive methods. I know, for example, that here in DC, that patients have had trouble getting sterilization procedures, and that it may take several months for someone who wants to have a sterilization to be able to schedule and arrange and get insurance pre-authorization for that procedure. That means that even though their desired method of birth control is to have a sterilization procedure, they still need a method of contraception today, something to make sure that they can get from today to that visit and to the time when they can have their procedure. All right, so we're going to put this together with some scenarios. I think there may be a question here. All right, I do not have any questions right now. Okay. So as I discussed in the beginning, we'll be using one key question for the following scenarios. So this is the clinical algorithm to start conversations about pregnancy desires and contraceptive needs. For those who are not clinical providers, there is a separate non-clinical algorithm. Again, for these scenarios, we'll be talking a little bit through the clinical scenarios in addition to just the counseling. So our client for this first scenario is a 25-year-old woman with 4 children. Her youngest child is 7 months old, and she is not currently breastfeeding. She has an on-again, off-again partner and does not want any more children. She has no medical history and is not currently taking any medications. When asked one key question, she answers no. She does not want to be pregnant in the next year. So some follow-up questions from the algorithm that we can ask her are you currently using a method of birth control? So she reports that she and her partner are using condoms most of the time. I think it can be challenging when someone says, yeah, I use condoms most of the time, some of the time, to really determine what that is. A clarifying question that I like to use when talking about condoms is, in the last 10 times that you had sex, how many times did you use a condom? To really be able to get better information from your client in a way that helps you understand how consistently they are using a method. Or if they're using pills, in the last pack of pills that you had, how many times did you take a pill late or miss a pill altogether? So asking the client, how's this method working for you? So this client reports that it's going okay, but they're not using them all the time, and her partner is particularly resistant to using condoms. So that's one of the tricky things if you're using condoms, is making sure that partners are in agreement about their use. How important is it to you to prevent pregnancy? She reports that it's very important to prevent pregnancy and does not want any more children. And so then asking also, what is most important to you in a birth control method? So because it sounds like maybe that because her partner is resistant to using condoms, she'd like to start a method that's easier to use. And because it's very important to her to prevent pregnancy, she'd like something that's more effective. So if you're not a clinical provider, these are still questions that you can ask. But if you're a clinical provider and you're going to be offering contraception, to be reasonably certain that someone is not pregnant, there are some additional clinical questions. Asking about the first day of the last normal menstrual period, asking about unprotected penis and vagina sex since the last normal period, and asking about penis and vagina sex in the last 5 days to assess whether someone needs emergency contraception. These other questions about spontaneous abortion or delivery and breastfeeding are things that you would usually have some information about whether you would ask those questions. However, depending upon your site, you may not know that someone recently had a miscarriage or an induced abortion. It's important to note that those clients who have had a miscarriage or an abortion who have been pregnant in the last 7 days may continue to have a positive pregnancy test, and you can still be reasonably certain that they are not pregnant. So it is important, not necessarily, a pregnancy test can be useful information, but it is not the only tool used to determine whether you can start a method of birth control today. So for this client in our scenario, we're going to ask which of the following are best next steps. So A, this client is using a method, condoms, so there's nothing else to do. B, offer counseling, educational materials, and/or a referral on birth control methods today. C, offer client to start a method of birth control today. Or D, talk to the client about barriers to using condoms more effectively. Or E, B, C, and D. For everyone, just another 10 seconds or so here. All right, and I think we can go ahead and close the poll. Great. So everybody got that right. The correct answer is B, C, and D. So, all right, let's go ahead and we're going to move into our next counseling scenario. So you're doing intake for a 32-year-old woman with 1 child. That child is 5 years old. She has no medical history and no current medications. However, this client smokes 10 cigarettes a day. This client answers unsure to 1 key question about whether she would like to be pregnant in the next year. So we'll go through some similar follow-up questions, although for someone who is unsure about pregnancy, we ask slightly different questions. So do you want to have more children in the future? And she says yes, but not sure when that would be. How would you feel if you found out you were pregnant today? And said mixed feelings, but overall happy. Ask about current use of a birth control method. So this client is not currently using any method. And then how important is it to you to prevent pregnancy right now? And somewhat important, unsure if right now is a good time for pregnancy. Offering the client to talk about some ways to prevent a pregnancy, they're open to that information, and then talking about some simple ways to prepare for a healthy pregnancy. They're open to hearing that information, and we aren't specifically talking about that during today's webinar, but you can also offer this client who is unsure preconception counseling and care if that's within your scope, or refer to another site that is able to provide those services. For this client, again, they smoke cigarettes, so thinking about what method of contraception might be a good fit based on this client's medical history and factors is something that you would use the medical eligibility criteria for. So we've got our final question here during our webinar. So which of the following are true? A, this client answered unsure, so they don't need a birth control method. B, this client may not want to start a birth control method today. C, since they were unsure, they only need information about short-term methods like condoms. Or D, this client would be happy about pregnancy, so I should only talk about preconception care. And E, B, and D. Another 10 seconds or so. Okay, I think we can go ahead and close. So the correct answer here is just B. So it would be appropriate for D to talk to the client about preconception care, but that's not the only thing that they need counseling on. So offering the client a combination of both preconception care and contraceptive care based on their needs is important when clients answer unsure or okay either way. Determining how much preconception or contraceptive care someone needs is based on their own individual preferences, goals, and desires. It's also important to remember that a client who answers unsure, okay either way, or even someone who answers yes or no may not want to start birth control or receive a referral for preconception care, and that's okay. So this last slide here to debrief about today's presentation. It's really just an overview of the basics of birth control methods and contraceptive counseling. After this presentation, you may not feel ready to counsel with confidence on all of the methods the next time you see a patient, and that's okay. If you're not able to directly provide contraceptive services at either you personally or at your site, thinking about your referral network and how to connect clients to the birth control services that they need. Remember, for those using one key question, that clients from all 4 response categories may have birth control needs. For example, someone who wants to be pregnant within a year may not want to be pregnant today and may need a method of birth control in the short term. And again, just to follow up, you don't need to be an expert to talk to clients about their birth control needs and desires and provide them with resources and a referral. So at this point, the presentation is done, but I'd be happy to stay on for as long as people have questions. And hopefully we can answer your questions now. And again, as I said, if you have other things that come up or you think about later on, please feel free to reach out and contact me. And so we've got a question, it's more of a comment here, that the CDC also makes a medical eligibility criteria app that is easy to search by patient condition or contraceptive method. So that is true, and it is a great resource. So you can go to the CDC for the summary chart, which I had a picture of here, and keep that at your desk. You can also use the app. We have another question here. So from an attendee, what do you do if they want an IUD, but you do not have that available and you're unfamiliar with the resources in your area? So you can also refer patients to Bedsider with the Clinic Finder. So they can put in their zip code, they can put in their city, and it will give them information on clinics that are close to them that would be able to offer those services. So that would be my recommendation. Since I am not familiar with your particular area, I think that is generally the best resource to help connect people to the providers that can offer the birth control that they need.
And this is Nagla. If there are any questions, again, please send them in. Meanwhile, I wanted to thank so much, Robin. This has been really informative. We've been sitting here and listening to it on our end, and we've found it really thorough, very, very informative. We really appreciate you and Power to Decide for this presentation. I wanted to just go through, while we're waiting for questions, a couple of things. This is related to the Texas Collaborative for Healthy Mothers and Babies, which is the Texas Perinatal Quality Collaborative. We are having right now an open call for clinics or providers who are interested in participating in the One Key Question, Quality Improvements, and Learning Collaborative, which is starting this fiscal year. We are probably going to extend the period for enrollment, which currently is this Friday, but the link is below. And clinics can go ahead and download all the documents. And please, if you have any questions, if you can contact us. Also, I wanted to announce our 2020 Texas Collaborative for Healthy Mothers and Babies Summit, which is scheduled for February 27th and 28th of 2020. And there may be also on the 26th some quality improvement training that we will be providing, and more on that to come. And again, thank you so much for everybody who participated in this webinar. If you still have questions or that you think about later, you can either email directly Robin or the Texas Collaborative for Healthy Mothers and Babies, and we will forward those questions to Robin. And this webinar will be is being recorded and will be available in the future within the next couple of weeks. Thank you very much.